Hopefully that's coming through okay. So what we're going to try to do here is cram all of the high yield stuff for pediatric surgery into about an hour. Um, it's kind of an impossible task, so I'll just try to go through everything pretty rapidly. So at least it's on the tip of your tongue, or like at least you've heard about it recently and you can catch the trigger for certain conditions. Um, I started with going through all of the bread and butter stuff of pediatric surgery, mostly intestinal things. So these things will pop up in a question here and there. Some of it is on every ABSITE, and I'll kind of highlight what those things might be as we go through. But these are all the conditions that I'll hit over the first half of this. Um, so I don't know. For me, when I ran into an ABSITE question with a baby, my first step was to panic, because trying to remember all that stuff when you're constantly doing adult surgery is hard. So I'm going to try to distill it down to the basics. So we've got a baby who's vomiting. Let's narrow it down. Is it bilious or non-bilious? And usually in the question stem, you're going to get the color of the vomit or something about how much it is, whether it's projectile or not. Um, Maybe you'll get some birth history, maybe not. And you'll definitely get the age of the infant, which can really help narrow it down. And then the exam findings. Is their abdomen distended? Is it scaphoid? Is it just normal looking? And is there a presence of a hernia? Uh, Guaranteed on every single ABSITE exam that I ever took, there was some question about hypochloremic, hypokalemic metabolic alkalosis with paradoxic aciduria. And usually they'll kind of mess around with how they phrase it. Like they'll say high chloride level and low urine pH. So you just memorize what the finding is, and you'll be guaranteed some points on the ABSITE. Um, Pyloric stenosis is a question stem favorite because this is practiced by general surgeons in a lot of the country, and especially in rural surgery. It's not a pediatric surgery specific thing. So this is kind of high yield for the ABSITE. Um, there are some uh, unexpected things that sometimes come up on the ABSITE. Pyloric stenosis has been associated with erythromycin exposure. Um, it is fairly common for a pediatric surgery condition, 3 out of every 1,000 babies. Males more than females, often the firstborn male. Um, and what we see, arises from hypertrophy of the muscular layer of the pylorus. Almost always in any question stem, they're not going to try to trick you. This will be non-bilious projectile emesis. Um, and the age is really critical. This is not a newborn. This is like 2 weeks to 2 months. So this wouldn't be immediately after birth that this develops. It usually takes a few weeks to show up. And similarly, the baby shouldn't be a year old. It should be 2 weeks to 2 months. Um, on physical exams, sometimes they'll tell you you can feel an olive. In reality, you can almost never feel the olive. That's a leftover from the old days when to feel that you would have to put in an NG tube, hold the baby prone while palpating the abdomen. So in real life, you can almost never feel an olive. But ultrasound is great for diagnosing this. And most of us remember that it's just pi. The width of the thickness of the wall is greater than 3 millimeters, and the length of the channel is greater than 14 millimeters, 3.14. So that can help you remember that. And upper GI is not as great for diagnosis. Ultrasound is really better, but you can see a lack of passage of contrast across the pylorus. One of the key things and this often will show up on ABSITE, is it might ask you what is the next best step. And if you haven't checked the electrolytes yet or corrected an alkalosis, then you have to do that before going to the OR. So don't go to the OR for a lap pyloromyotomy or an open pyloromyotomy until you've corrected the electrolytes. Because that is a critical fail on a board exam. If you haven't corrected an alkalosis, you won't be able to extubate the baby. And now they'll be going to the PICU intubated instead of onto the floor drinking some formula. So the pearls, always non-bilious projectile emesis. Not too young, not too old, 2 weeks to 2 months, 3.13 millimeters thick, 14 millimeters long, and definitely know your hypochloremic, hypokalemic metabolic alkalosis with paradoxic acid urine. All right, malrotation. The midgut develops outside of the abdomen. And when it's outside of the abdomen, it rotates 270 degrees counterclockwise and then goes back into the abdomen, and all the different parts fix where they're supposed to, like the cecum in the right lower quadrant, the adhesions to the paracolic gutter will form, the duodenum's fixed in the retroperitoneum, and the SMA passes over it. The ligament of Treitz should be to the left of the vertebral column, like you're used to seeing it on every single patient that you take care of. All of those steps along the way can get messed up. So one case of malrotation is not the same as the rest. There's a lot of variety in where it can get messed up. This is just a schematic of it. And one of the key things is that malrotation is not the same as volvulus. Volvulus can happen because malrotation is there. And I think a lot of people get that mixed up sometimes. Malrotation you can walk around with for 50 years without knowing that you have it. Malrotation can also cause these Ladd's bands that drape across the duodenum that can cause an obstruction that's not volvulus. So sometimes patients with malrotation have signs of intestinal atresia or a blockage of the intestine without being sick like a volvulus. And when a baby is sick in the question stem, you've really got to worry about volvulus. And you might be given a radiograph like this that shows a twisting appearance, and that is going to be volvulus every time. All right, let me see. There's the pictures. Okay, so when a baby has volvulus, 90% of these cases will present by the first year of age, and 75% in the first month. This picture up here on the right, on the top, that looks like a double bubble sign. And this is a trap for you because you're going to see double bubble sign and you're immediately going to think this is duodenal atresia. But it is important to know that you can have a double bubble sign with volvulus. So if the baby in the question stem is sick, you should suspect volvulus, especially if you see distal air beyond that. So don't always see the double bubble sign and think duodenal atresia. This can be volvulus. You can also see a gasless abdomen. The trick is you always want to get an upper GI. If you suspect malrotation, if you suspect volvulus, get an upper GI. So the pearls, malrotation alone doesn't always cause symptoms. It's not urgent, but volvulus is a surgical emergency. And if you've diagnosed a volvulus, the only place you should be going is the OR. Always get an upper GI. Ultrasound, you can diagnose volvulus or malrotation, but it's not as precise. It's not the choice that you'd make first. And double bubble does not always mean duodenal atresia. If the baby's sick, make sure to get an upper GI and suspect volvulus. You'll often get a picture like this on the test that's kind of blurry and hard to interpret. And if you see this target sign, then you know that this question is going to be about intussusception. That's a bit of a trick question because intussusception, most commonly, ileocolonic intussusception happens from 3 months to 3 years. And if it's not within that range, if it's a teenager with ileocolonic intussusception, then you should really be thinking about some other lead point, something like a Meckel's diverticulum or a lymphoma, something that is an abnormal trigger if you're outside of that range. A lot of times in the question stem, the key will be intermittent colicky pain. So the baby or child will be intermittently drawing their knees up to their chest and having bouts of pain that then last for about 15 minutes and then seem to resolve. You won't always get the current jelly stools, or maybe sometimes they'll show a picture of something that looks like it might be a bloody bowel movement. Um, so don't just hang your hat on current jelly stools. It's that chronic or colicky abdominal pain that should really make you suspect it. And usually the diagnosis is by ultrasound, and then you'll see that target sign. Sometimes the question might throw you off by giving you a small bowel intussusception. If you see that on a question, those will usually self-resolve. They're often secondary to a viral infection, and might be from hyperperistalsis of the bowel. But ileocolonic intussusception, you should treat with an air contrast enema, as long as the baby isn't sick. If there's free air or signs of peritonitis, then you got to go to the OR. And so that should be fairly easy to remember is if they're not sick, you can reduce it with air. If they are sick, then you should go to the OR. An important thing to tell every family is that there is a high chance of recurrence. There's less of a chance of recurrence with OR than with air contrast enema, but it's about 10 to 15%. So, yeah, we went through all those things. A Meckel's diverticulum. The most common presentation of Meckel's diverticulum in children is actually bleeding. And what you'll see is usually painless lower GI bleeding. So bright red blood per rectum, but no pain. Unfortunately, Meckel's can present in a whole bunch of different ways. They can be an incidental finding while you're doing some other procedure. They can be the painless rectal bleeding. They could be inflamed and have Meckel's diverticulitis, or they could perforate and have perforated Meckel's diverticulitis. So all of those things are possibilities. They can also have an obstructive band. But depending on the question stem, the most common would be bleeding. Meckels are found on the anti-mesenteric border, so that it's always opposite the mesentery, and they result from a patent vitelline duct. I've seen that on ABSITEs before. I'm not sure why you need to know that, but it might come up. And this is the #1 cause of painless GI bleeding in children. You've all heard the rule of twos, so this should be within 2 feet of the ileocecal valve. It's overall thought to be 2% of the population based on autopsy studies, but only 2% are actually symptomatic. And the diverticulum itself can contain one of 2 different tissue types, pancreatic or gastric. And both of those can cause ulceration, which is usually in the area of that blood vessel that's running along the side of the Meckels there. And can cause the bleeding. Meckel scans, they detect gastric ectopic tissue, so there's a high rate of false negatives. So for example, if you want to know if there's a Meckel's and you do a Meckel scan and it's negative, it could still be pancreatic tissue within there. So a lot of times what you have to do is a diagnostic laparoscopy. Our abdominal wall defects. Remember this being a source of common ABSITE questions. If you see bowel without a sac, that's a gastroschisis. If you see a sac around it, that's an omphalocele. There's a lot of differences between the two. And I'll just kind of go through some of them. An omphalocele is a central defect. Um, it's a midline problem. And gastroschisis is always to the right of the umbilicus. Uh, if you had to ask which of these is worse to have, usually omphalocele, because about 30 to 80% have associated other problems, like chromosomal abnormalities, or the most significant would be heart disease. This can be associated with Beckwith-Wiedemann or Pentrology of Cantrell, which I listed all that stuff there. Um, and sometimes this can cause pulmonary hypoplasia just because of the abnormal growth of the chest that comes along with this. Um, both of these conditions have malrotation by definition, because the intestine is definitely malrotated. Gastroschisis does not have a lot of associated congenital anomalies. And what you would typically do as the first step is put this in a silo. If you're going to be answering something for the boards, I think that's the safest thing rather than try to plan for immediate closure of this. When you have an obstruction in an infant and this is a newborn, you have signs of intestinal obstruction, there's air proximally but not distally, you often have to suspect an intestinal atresia. And this could happen at anywhere along the line of the intestine, but they're most common in the jejunum, followed by ileum, followed by colon. These are usually caused by vascular problems in utero and subsequent ischemia. Sorry, the ileum is more common than jejunum. You'll have abdominal distension, but you won't necessarily have it the first day of life. So most of the time, the baby will feed normally for a few days, or maybe not that great for the first few days, but then they'll start having bilious emesis. We start out with treatment by NG tube decompression, and they're going to need the OR, but it's usually less emergent and more urgent over the next few days. They usually won't give you different type questions about what the actual type number is, but just in case, type 1 is where there's just a web or a blockage in between. Type 2, there's a little string in between. And type 3, you start to have an actual gap in the mesentery. And type 4 is multiple different links. So there's several different areas that are blocked and not connected. Duodenal atresia is different than the other intestinal atresias. This is thought to be from a failure of recanalization of the duodenum. So instead of a vascular problem causing the intestine to necrose and become ischemic, this is from a failure of development, where the duodenum as a tube becomes solid and then reopens again, recanalizes. This is highly associated with trisomy 21, and also vectoral lesions. The types of duodenal atresia are fairly similar to the types of intestinal atresia. You can have a web inside the duodenum. You can have the two ends just not connected whatsoever in type 3, or you can have a little cord that's fibrotic in between them. The main treatment you see on the right side here is called a kimura anastomosis, or a diamond-shaped anastomosis, where you make the proximal incision transversely and the distal longitudinally so that you can attach a larger proximal area to a smaller distal. This is the classic double bubble sign. Duodenal atresia can actually have bilious or non-bilious vomiting. It depends on the level of the atresia. So don't get fooled by every non-bilious vomiting must be pyloric stenosis, or every bilious needs to be malrotation. This one can be either one. I think that's probably good for that. Imperforate anus. So this is when there's some abnormality of where the rectum ends. This is more common in males. It's associated with vectoral, and the types can either be high or low. So I'm going to skip and show some pictures instead. On the picture to the top, all the way to the left, you see a connection from the colon to the bladder. In the next one, you see a connection from the colon to the urethra. And then the third, a connection to the perineum. And so those are the different varieties, and you approach them differently. If there's a high one, then you approach it laparoscopically or transabdominally, so that you can disconnect that fistula from the bladder or the urethra. The low ones that have a fistula to the perineum, you can do through a posterior sagitto-anorectoplasty, meaning you put the baby prone and you work from the bottom up towards the rectum. Another thing that sometimes might come up would be cloaca. And a cloaca is when all of the urethra, vagina, and rectum all empty into a common channel. So instead of having three separate distinct openings, you just have one. And the treatment for this is probably beyond the scope of the ABSITE, but you essentially separate the structures surgically and so that they're able to function and not empty through the same channel. You might get a radiograph like this, where what you're looking for here is, let's see if I can show it, is the air within the bowel wall. When you see intestinal pneumatosis like this, what you're going to find inside is this. This is necrotizing enterocolitis. And they do like asking questions about enterocolitis on these exams. It can be probably the number one predisposing factor is prematurity. But this can be from a bunch of different problems, including cardiac defects. So if you always have a low perfusion state, you're not going to be perfusing the bowel very well, and that could lead to necrotizing enterocolitis. One of the big discoveries for necrotizing enterocolitis is that breastfeeding helps prevent it. So the use of formulas, especially with fortification, so when you add extra calories to the formula artificially, that is a risk factor for necrotizing enterocolitis. So fortified feeds, especially formula feeds rather than breast milk, make enterocolitis more likely. This usually happens within the first 2 weeks of life, especially in premature infants, but it can happen later too. It can also happen in preterm infants, and unfortunately tends to be a little bit worse in full-term infants. What we're going to look for on our x-rays is pneumatosis, portal venous gas, or free air. If there is free air, then we're going to do an operation. For the other findings, we treat with bowel rest and antibiotics. There are times in very small infants, less than 1 kilogram, where if you see free air, you would consider placement of a drain instead of just going to the operating room. That's a little bit controversial, and so I don't think that'll be on the ABSITE, but it is an option. Hirschsprung's disease. This is one of the colonic obstructions that can happen in infants. So what this is from is the absence congenitally of parasympathetic ganglia in the colon. This is more common in males than females, except for total colonic Hirschsprungs, which is equal. It does tend to run in families, but it's not strictly genetic, and it can happen from de novo mutations as well. You suspect Hirschsprungs if you've had failure to pass meconium in the first 24 to 48 hours. So usually the question stem will give you that. And they'll have abdominal distension. They can have bilious emesis. Um, and we should always suspect Hirschsprung's disease if there's problems with constipation in a young infant. We also know that about 20% of cases of Hirschsprung's escape out of the newborn period. So they are not picked up as an infant. And they're only picked up later through usually years of chronic constipation before somebody decides that we should do a biopsy. One of the worst things that can happen with Hirschsprung's disease is Hirschsprung's associated enterocolitis. So this is a bacterial overgrowth within the colon, and they can suddenly get incredibly sick, basically have out of the blue fulminant sepsis. And so you treat with antibiotics and usually colonic irrigations to help get that stool out. The goal surgically for Hirschsprung's disease is to pull through the part that doesn't have ganglion cells. And so there's a bunch of different operations that you can do to do that, but the idea is all the same with all of them, is get rid of the abnormal intestine. Meconium ileus. This is often presents the same as an intestinal atresia in terms of symptoms. But in the question stem, usually they'll give you something suggestive of like they failed their sweat chloride test, or there's a family history of cystic fibrosis. This can cause perforation, and usually what you'll see is like a cluster of calcifications around the peritoneum um, that that might suggest meconium pseudocyst. Generally, you can treat these with gastrographin enemas, like basically high osmolarity contrast to try to get things to pass through, or you can use N-acetylcysteine. Sometimes we do have to operate to take out that inspissated meconium and flush everything through. Hernias are incredibly common and fair game for the ABSITE as well. They're more common in males and more common on the right side rather than the left side. In children, this is almost always due to the non-fusion of the processus vaginalis. So the etiology is a little bit different than adults. Premature infants have a higher chance of inguinal hernia. And usually inguinal hernias are more common in patients with VP shunts or connective tissue disorders or on peritoneal dialysis, things that increase intra-abdominal pressure. The difference between a hernia and a hydrocele will be prominent scrotal swelling without swelling in the inguinal canal. So there's and often you'll hear that it transilluminates or something like that. So that's basically just filled with fluid. If you have a communicating hydrocele, you treat it the same way as an inguinal hernia, is you got to repair it. If you have a non-communicating hydrocele, then you can repair it at around a year and a half, or if it hasn't closed by age 2. Most kids with inguinal hernias will present before 6 months of age. The risk of incarceration is significantly higher in premature infants, and so you should not wait to repair it, say until they turn 3 years old or something like that. So even if it's asymptomatic, you operate when they're a baby. We know that it's safe to wait until about 60 weeks gestational age, so you can let them get home from the NICU and come back, but you shouldn't wait too long. And switch gears from the intestinal stuff to some of the just high yield pediatric surgery specific conditions. Biliary atresia, not very common. It's 1 in 25,000 births. So we get maybe a handful of suspected cases every year. But this is one where if you don't recognize it early, they can get into serious trouble and not have a survivable condition. So the sooner you diagnose biliary atresia, the better it is for the baby. And what you'll usually get in the question stem is something about pale acholic stools. So maybe the parents have noticed that the stool is really pale and has changed in color over time. That should be the trigger that you need to do a test for biliary atresia. Uh, it's the different types of biliary atresia. I don't think this is very high yield for your test, but know that you can actually have a normal looking gallbladder, that just the presence of a gallbladder doesn't mean that you don't have biliary atresia. Um, if you suspect biliary atresia, the test you have to do is a cholangiogram. Um, and it may seem overly aggressive as a question or an answer that you pick to do an open cholangiogram. But sometimes in an infant, that's all you can do. You can't do ERCP or percutaneous cholangiogram. You have to open and put a purse string in the gallbladder and basically do a cholangiogram through the gallbladder. And if it shows that there's biliary atresia, you proceed immediately to a Kasai procedure, or a hepatoportal jejunostomy. Basically, you take down all of uh, the useless common bile duct remnant all the way up to the portal plate, and you just attach the intestine to the portal plate of the liver and hope that those tiny ducts flow into the intestine. And um, it's not the best surgery. About 30% are fine, at least for a few years until they need a liver transplant. Um, a good portion of them will go on to transplant. And what we're really trying to do is bridge them to get to the point where they can be transplanted. And 30% die still. So I think we have a lot of work to do on biliary atresia. Thyroglossal ducts. This is pretty common on the ABSITE. If you see a midline neck mass, Um, it might be infected, it might be red or swollen, or it might be kind of benign or bland looking like this, or asymptomatic. But the key is midline and pretty high up on the neck. You should suspect a thyroglossal duct cyst. This arises during the migration of the thyroid. So the thyroid passes down from the branchial clefts down to its expected position in the lower neck, but along the way it leaves this tract behind. Um, and the cyst can develop within there, and it has a pathway through the mid portion of the hyoid bone. So what you have to do is called a cyst trunk procedure, where you take out the mid portion of the hyoid bone as well as the cyst and the tract, and that significantly cuts down on recurrence. If you see lumps on the lateral part of the neck, especially anterior to the border of the sternocleidomastoid, you suspect branchial cleft cysts. So usually you can diagnose this with ultrasound. There's different places they can be, from the angle of the mandible to the most common, which is along the anterior border of the SCM, or on the lateral portion of the neck and posterior to the carotid bifurcation. What you need to know is that for all of them, you basically excised the cyst and its tract. A cystic hygroma, you might get a picture like this that's also blurry and hard to interpret if the ABSITE is still similar to when I was taking it, where there's a big lump on the side of the neck in an otherwise asymptomatic baby. And something like that is called a lymphangioma. It used to be called cystic hygroma. They're fairly common and basically are just a big pool of lymphatics. A lot of times these do not need resection. They're treated with serial sclerosis and by IR more often than surgery now at this point. One thing that can come up is if a baby has a hard, firm mass in the center of the sternocleidomastoid muscle. They might try to trick you with what to do about it, whether or not to biopsy. Um, this is torticollis, and usually you can just treat with PT and basically stretching the neck. So a palpable mass within the sternocleidomastoid, you can actually just do PT for, uh, and not a biopsy or anything. If you get a chest X-ray like this with all of the intestine in the thoracic cavity, you know you're dealing with congenital diaphragmatic hernia. They love asking what is the most common location of a congenital diaphragmatic hernia. And you might remember Bokdelek, back to the left. That's how I always remembered it. So it's a left-sided posterolateral. And an anterior, more midline hernia is the Morgagni hernia. Most patients with congenital diaphragmatic hernias do have associated abnormalities, and it's mainly cardiac and significant pulmonary hypertension, as well as pulmonary hypoplasia. This can be identified on prenatal ultrasound, but usually in the question stem that you'll get for the ABSITE, it'll be an X-ray that shows bowel in the chest. They may ask about timing of surgery. It's pretty controversial, and in general, you do the repair when the baby's stable, or you try to find a window where they're stable to get a repair. If they don't get that window, then you might need to cannulate for ECMO and do the repair on ECMO. They will usually ask a lot of questions about what are the different parts of Bacteral. So it's good to just try to keep that in your memory. They may also ask about the most common type of tracheoesophageal anomaly. And the most common type by far is type C, which is proximal esophageal atresia with a distal fistula. So you can see that blind ending pouch in C here. And then there's a connection to the trachea distally that goes on to the rest of the bowel. So if you get an X-ray for type C, you will see air in the distal, in the intestine. Though they may also show a coiled up NG tube in the proximal esophagus. And if they show you something like that on the ABSITE, that's definitely esophageal atresia. A pure esophageal atresia, or type A, will not have distal air because there's no connection to the distal intestine. If they tell you the patient has an esophageal atresia and you see a huge gastric bubble like this, then you need to go to the OR immediately to ligate the fistula because they're getting too much air in the distal intestine and it's trapped, and that can cause a decrease in preload that causes them to code. When you have esophageal atresia, you basically want to figure out how to connect the two ends of the esophagus. I think that's probably beyond the scope of the ABSITE. You can have, so this question is a 2-week-old with respiratory distress in the emergency room. And they might show you this radiograph that looks like a pneumothorax. It has mediastinal shift, but if you look closely, you can see lung markings on the left side. So this is not a pneumothorax, and we shouldn't place a chest tube. This is called congenital lobar emphysema. The treatment for this is a thoracotomy to open it up and relieve the pressure and then remove the affected portion. This is a variant of what's called a CPAM. There are a number of airway malformations that can happen in infants. The most common are these cystic proliferation that you see in this CT on the right. And the treatment is resection. So the other thing that can happen is what's called a sequestration. And so in this picture down here, you can see an intralobar sequestration. So that's It's within the lobe of the lung, and an extralobar outside of the lobe of the lung. So it's not really connected to the lung itself. Neither one of these communicates with the tracheobronchial tree. It's sequestered, it's on its own. And they do get blood supply from the aorta. So that comes up on ABSITEs from time to time. This is just what that looks like intraoperatively. Another thing that can happen is a bronchogenic cyst. So you can have intestinal duplication cysts, you can have bronchial duplication cysts. So basically, just things didn't develop right, and there's an extra cyst, and the treatment is resection. Mediastinal masses. One of the important things with mediastinal masses is don't immediately put them to sleep for a biopsy because you need to find out if the mass is compressing the great vessels. If you give them anesthesia, they might have cardiovascular collapse and code. So it's important to figure out how can we get a biopsy without putting them under anesthesia. One of the most common mediastinal masses in children is actually a neurogenic tumor, so a neuroblastoma or a neurofibroma or ganglioma. So there may be another way to biopsy besides just going after the mediastinal mass. For solid tumors in kids, I think probably they'll just want to distinguish between Wilms tumor and neuroblastoma. So Wilms tumor affects either kidney or it can be bilateral. And this is usually in kids age 1 to 3. It's not common, but there are associated conditions like Beckwith's, Wiedemann, and let me show you the CT scan. So on the CT scan, what you'll see is a large mass that doesn't always surround other blood vessels. It kind of pushes things out of the way. And it has what's called a claw sign or a little bit of normal kidney. That I don't have a way to point out on here, but basically the kidney is pushed to the side by this. And either you resect it primarily if you can, if it doesn't cross midline. And if you can't, then you do neoadjuvant chemotherapy and then resect it. For neuroblastoma, this is usually adrenal origin. It can also arise from the organ of Zuckerkandl at the aortic bifurcation. This is the most common extracranial solid tumor of childhood. So often these kids are age 2 to around 6 when they present. And there's a spectrum of it too, from benign tumors like ganglioneuroma all the way to neuroblastoma, which is malignant. And this can happen anywhere along the sympathetic chain. You may see some pictures of somebody with black and blue eyes and not mistake this for abuse, but this is a classic sign of neuroblastoma. And so you should get an abdominal ultrasound to try to look for an abdominal mass. You may also see these blueberry muffin spots, and that you could biopsy if you needed to get the diagnosis of neuroblastoma. Neuroblastoma does wrap around blood vessels and push things out of the way. And most often, if it's at an advanced phase, you have to treat with neoadjuvant chemotherapy to shrink it down before performing a second look resection. Hepatoblastoma is the most common liver tumor in kids. And this will usually present with increased AFP. It's also associated with Beckwith-Wiedemann syndrome. So if you ever had to guess some associated syndrome, always pick Beckwith-Wiedemann. And vascular invasion is pretty common. It depends a lot on the distribution of the tumor, whether or not they should go to a transplant center to consider transplant, or whether a lobectomy could be possible. And the last thing I've got is foreign body ingestion. And one thing that you absolutely can't miss on the ABSITE or in real life is if you see a foreign body and it has this ring around it and it's stuck up here in the esophagus, that is a button battery. So these high voltage quarter-sized lithium ion batteries, when they're trapped in the esophagus, they kind of wedge into the esophagus, and that completes the circuit, and it activates and starts to produce hydroxide radicals that cook the esophagus. So it's both a heat injury and a caustic injury, and it can cause basically devastating effects. We've seen aortoenteric fistulas. We've seen erosion into the trachea, kids requiring tracheostomy. A lot of times we remove this immediately and place a G-tube so that they can be NPO for weeks. So just something that absolutely not to miss. If there's a question stem about it, proceed immediately to the OR. And that's what I got. Let me stop sharing my screen. All right, and I'm happy to take any questions there might be in the last couple minutes we've got left. I know that was a whole bunch all packed in there.